Once again. Thank you, Boston, for inviting me for this session. I will be talking about the basics of Ivus, the images which we see in Ivus, right? So they gave me a topic of stranger things. What do you see in an Ivus, right? What is Ivus? Basically, I just talk basic things. Is intravascular ultrasound sonography. It is just a device that provides you the imaging of the anatomy of the vessel and what you see within the vessel, right? In most of us who do angioplasties, when we see a vessel, so proper vessel sizing, the limitations of vessel sizing techniques in an actual size, you see, if you see that 3.0 mm diameter, OCT gives you a virtually accurate diameter, but Ivus slightly overestimates. QCA definitely underestimates the vessel size. And as we go on, the margin of error towards the right, where visual estimates are very grossly inter-observational variability is there. So as we recognize the risk of underestimating vessel size by visual estimation, your value of Ivus and OCT is always there. What can be seen by Ivus? Basically, we'll go to the anatomy of the vessel. In the Ivus image of the coronary artery, you get three layers: the intima, the media, and the adventitia. The intima here, the media, and the adventitia. You can see in a highly magnified vision, the intima, the lumen, and then the intima. And it is just a homogeneous smooth muscle cells in the media. And adventitia, you see sheets of collagen that reflects a hyperechogenic area, this area, which is hyperechogenic. In this muscle tissue, muscle cells in the media, you get hypoechogenic transmission, right? And what is important here is that you can see the lumen CSA and the media to media diameter of a vessel, especially when you want to place your stents, right? And the parameters of cross-sectional area will be the lumen CSA, A, the vessel CSA, B, and the plaque CSA, which is the vessel minus the lumen CSA. So these are important measurements when you come into interpreting the cross-sectional area of your vessel after stent placement. What you see in a vessel, basically when you see in this vessel, you can see calcified plaques. Calcified plaque can be seen, which shows hyperechogenicity. Only the leading edge is detected. The full thickness cannot be determined since calcified plaque obstructs the penetration of the ultrasound. So you can see superficial calcification or deeper calcification. And this can be in various segments. You can see this one is quite superficial, quite concentric. This is between 9 to 12 o'clock position, and this is segmental in the 12 to 2 position. In a fibrous plaque, you see bright or brighter than the adventitia. This is the adventitia, and you can see a fibrofatty plaque. It is hyperecho. The majority of your atherosclerotic lesions are fibrotic. Most usually you would not see such simple plain plaques. You will see mixed plaques. Plaques frequently contain more than one echocystical subtypes. They are fibrocalcific, as you can see here, or fibrofatty. So you will see a mixture of both calcification and fibrous tissue. And this is the other entity known as attenuated plaques. These are hypoechogenic plaques with deep ultrasound attenuation without calcification. This you can see in certain areas in recent infarcts and where the thrombus is there, where you see microcalcification and microcirculation. The problem with this attenuation plaques in recent studies shows that if you place a stent edge at this area, you will get a lot of no flow, reflow phenomena because of thrombotic plaque shift. In the other, what else you can see in the Ivus is that coronary dissection, especially after stent placement or stent or balloon dilatation. You can see this edge here, and there is dissection of the vessel, right? This is also very well seen in the Ivus image. Hematomas are another entity which you can see. This is a true lumen, and you can see a disparity between the true lumen and the adventitia within the media, where there is hematoma within it, right? It is a separation between the media and the adventitia, creating a pseudolumen full of blood, okay? This is a hematoma. The other entity which you can see is a thrombus. It's an intraluminal lobulated mass. And there is evidence of blood flow within it, with microchannels within the mass. There is mobility and sparkling or scintillating images. So this is within the lumen, and this is a thrombus, usually in the acute setting of coronaries. The other entity which you can appreciate is plaque rupture in thrombus. As you can see, there is a thin fibrous cap which ruptures, forming thrombus in this illustration. And subsequently, with resolution, you get a stenotic lesion with a thick plaque formation. All right? In the Ivus image, you can appreciate a residual plaque fibrous cap which ruptures and forms a cavity with thrombus. And this is also interpreted here with the ulcerated plaque. It's recognized as ulcerative Ivus image, all right, with a fibrous cap. Other artifacts which you can appreciate other than the usual, just air bubbles. When the mechanical scan, Ivus saline flush is not done. So what you have to do is flush the catheter so that to clear the bubbles, okay? And this can clear the images. The other one is the non-uniform rotational distortion, where the catheter is not coaxial, and you can see a rotational distortion of the Ivus image. This is the other version where you can see a guide wire artifact here, right? Sometimes this you would appreciate in certain lesions where you can see there's a false lumen and your guide catheter might have entered a false lumen. So you can see the difference between the wire in the true lumen and the false lumen. So the visualization of the guide wire shadow is in the lumen area, which is deflected here. What are the Ivus image in orientation and landmark? This is quite interesting, actually. If you can see, this is animation of what left anterior descending artery with the circumflex branch going up to the apex. And these are the branches of the septal branches and the diagonal branches. What is interpreted here, you can see from here, this is the pericardium, pericardial, this is a muscle area. This is the left ventricle ventricular area and the right ventricular. You just have to imagine this anatomy, right? If you see this is the left main, the circumflex, this is the pericardial area, this is the LV side, this is the RV side. If you put an image of yourself there, sorry, I did, am I going? Okay, that's right. Okay, if you put an image there, the head faces the pericardium, so the left hand goes onto the diagonals, the right hand faces the septal branches. This is just an illustration of sometimes when you see Ivus image, you're wondering where is the septal branches, where's the diagonal branches. So this is how you appreciate that. If you see the movement here, you can see the diagonal face the left hand, and 90 degrees to that will be the septal branches. So sometimes you can appreciate where the septal branches are and where the diagonal branches are in your Ivus image, right? Septal branches will appear on the opposite direction of the pericardium, and the diagonal branches usually is about 90% clockwise to the septal branch, okay? And the circumflex appears from the same direction as the diagonal branch, right? So just an illustration of how to differentiate between the septal and the diagonals. The other value of Ivus is to see the measurements, Ivus measurement to determine the stem size. Stem size, first you find the ideal proximal and the distal landing sites where you would put your stent edges. Second, you measure the lumen diameter for selecting the stent size. Please remember when you select the landing areas, it's normal to normal. And only the Ivus will help you determine this normal to normal. Lastly, you measure the length between the sides and determine the stent size. Always be careful of vessel remodeling. As you know, positive remodeling and this negative remodeling in myocardial bridging is always a concern when you put stents across. When you determine how do you determine the reference site? You would choose a normal vessel site. You would choose a site with a plaque burden of less than 50%, okay? And you would choose a site with a minimal plaque burden to land your stent to prevent plaque disruption, all right? This would be helped by your Ivus imaging. In how to determine the stent sizes, definitely Ivus does help. And here, as you can hear, say media to media is about 2.8. Media here is media to media is 1.59 at B, and C media to media is about 3. So the stent selection would be appropriate. Here it was selected as a 2.75 upgraded to a 3.0 post dilatation. So you got a 275 times 33 and upsized to a 3.0 post dilatation. The role of post-intervention Ivus is also, so you have done pre-intervention, how to identify your stents, sizing, and now post-intervention to assess the endpoint of the procedure. The key factors are stent expansion, whether your stent is under-expanded, stent apposition, whether it's malopposed, whether some of the struts are not opposing against the vessel. And please look at the stent edges to look at dissection and residual plaque burdens, and look at the coverage, whether you've gone normal to normal. Okay, and the next issue is post-stent Ivus evaluation, the importance of post-dilatation. As you can see here, a 3.5 stent was implanted. MSA stent area is about 7.2. When you post-dilated with a 4, depending on the media to media diameter, 4.0 balloon was performed, dilated, and the MSA increased to 10.4 with a well-opposed stent, right? And then you would like to look at stent malapposition, where the lumen surface and the stent struts, you will see all these are malapposed, right? These are the struts here of the stent, and this is a vessel lumen, right? This would only be identified with the Ivus and corrected by a post-dilatation of your stent. In-stent stenosis is also refers to re-narrowing the treated blood vessels. It's commonly caused by neo-intimal hyperplasia that has a very low echogenicity. Flushing with saline can help differentiate tissue borders. So that will help with what is your next line of action in ISRs. So in summary, what we understand from Ivus is the fundamentals of Ivus is the key to utilize Ivus in your cath lab. We can identify plaque characteristics by Ivus. We can identify the abnormalities within a vessel. Your co-registration with the Ivus image and angiograms are important for making better strategies in your PCI procedures. Ivus guided PCI with optimal results shows the best outcome than plain angio guided PCI. Thank you.